So just let everyone know this call is being recorded and that on entry, everybody was muted because of the number of folks in this call. We're going to use the chat feature. So when I ask polling questions or if you have questions for the speakers, please put those in chat. It kind of helps keep us organized and we'll pull those out and use those for discussion and questions for the speakers of the networks as we go forward. Everything from this meeting will be shared out or posted to the ESRD NCC website. So don't feel like you have to, hurry up and take notes. Just be present, stay with us, and we'll send out all the materials after the call. Who is on the call today? So we have facilities, dialysis facilities and transplant professionals. We have ESRD network staff. CMS is a co-host and they join these calls with us. And then also this call is open to patients and families. So those are the folks gathered today to hear about removing barriers to home dialysis. So that's really our objectives for today, is to talk about and identify some of those barriers that, by removing them, we could lead to greater home dialysis adoption. Also talking about from the facilities, how they could strategize and operationalize the drivers that are in the NCC home dialysis change package, again, at that facility level. And then how can we establish support systems to sustain folks on home dialysis? So Learning and Action Network, we like to emphasize the action part of this. And so this is a way for us to spread best practices. So, we ask you to be present. Thank you for taking this time with us. Please, spend the time with us. I know it's difficult with emails and meetings and other things. So really be here, listen and share, ask good questions, identify, start thinking, how could I use this at my facility or what might make sense for us? And then we ask that you take one idea from today's call and, share that with your team and apply it back, where you're working right now. And that, again, as we're all here together, we're committing to learn from each other as peers, as an all teach, all learn environment. Okay, so we like to just add a couple of ideas, plant some seeds in your mind as you listen to the speakers, so we call these questions to run on. So one of them is, what aha concept might you hear today that, makes sense for you and you could introduce back to your team? Also think about what are the possible benefits to using that home dialysis change package. Again, I'll talk a little bit more about those, but it's best practices that we pulled from top performers in home dialysis. And then, what else could your organization, could your facility, could your team do to really adapt this approach to your individual facility and to your needs to increase and sustain those home dialysis treatments? So the first polling question, we're going to try out this chat feature. So the first question here is, have you used any of the best practices from the change packages? Have you looked at the ESRD NCC change packages? Just drop your answers there in chat. Okay, good. Thank you, Twyla, for being the first one to say something. So just drop those in and we'll look back on it and we'll keep moving forward. Okay, so again, just a plug here for these change packages, right? OKR change packages. So you can see here, we have them in all different flavors. Today we're focused on the home dialysis, but we have them also for patient experience of care, transplant, increasing vaccinations, and more are on the way. So look forward to those. Again, these are best practices that we went to top performers in the current space with the current regulations who are figuring it out, and we're packaging these up and sharing them out. So it really could just be a playbook for anybody in a facility level. And I know how helpful real tactical information can be when you're running a clinic. So this is a snapshot at the end. I have a QR code. You'll be able to go right to it. But this is a snapshot of the home dialysis change package. And we have, primary drivers, which are the big picture items. And then under there, there's secondary drivers, which would be the actions you could take. So if you haven't looked at that so far, I see a few folks have answered no in the chat. If you haven't, it's something to consider and lean on as we, move forward in working on your home dialysis adoption rates at your clinic. So without further ado, I'm going to pass this to Donna DeBello from Network 15. You can see there the many states that Network 15 covers. I'm going to pass this to her to share her speaker, and we can all listen in to the good work they're doing. Donna?
Hi, everyone. Today, I'd like to introduce Sara. So Sara Eve, if you can go to the next slide. Yeah, I'd like to introduce Sara. She works with Fresenius Medical Care. She's a group facility administrator, and she's also an area team lead overseeing several facilities in the Denver, Colorado area. So today, Sarah's going to discuss with us her quality improvement efforts at the Rocky Mountain facility. So Sara, thanks for joining us and sharing your quality improvement efforts. And could you tell us a little bit about the barriers you first identified in that facility to transitioning patients to home dialysis?
Sure. Thanks, Donna. So one of the biggest things that I think a lot of facilities are facing is the same thing that we did. So we just had lack of staff. It does take one-on-one time with each patient. And when you do not have the staff for that, I think that's like the biggest barrier because we just don't have time to provide that education that we all know that we should be. Another barrier that we kind of, identified was just the disjointed education. We had a great education program, but we just did not have a streamlined curriculum, nor an easy way to get that information to the patients. It was turning out to where patients were just handed packets and here you go, and then that's where it stopped. And there's so much more to it. Just having patients that are comfortable with Incenter. So instead of patients going directly to home therapies, they were coming in center. They had crashed into Incenter. They had just been told that, you have to do dialysis to prolong your life. And then they just got comfortable of being taken care of. So they just didn't want to hear about home therapies. And that was just difficult to change those patients' minds about that, or we would have patients that didn't do well in home therapies and now they're in center and they're sitting in the lobby and they have very negative things to say. So new patients don't want to hear it. And then a barrier that I think not a lot of people identified, but we did. So we actually found that one person being named the home champion was a barrier to us moving patients to home because it was almost as if giving the team permission that they didn't have to be home therapy champions, that it fell to this one person. So we just found that that did not work for our facility.
Can you tell us a little bit more about what kind of educational materials did you use? I know you use a lot of Fresenius has a lot of educational pieces, and did you use other pieces from the NCC or the network, or what kind of education were you able to provide to your patients?
So one of the biggest ones that made a difference is we have a patient advocate. We have a couple patient advocates just thrown throughout the Denver metro area, but to have a patient that can actually talk to another patient, whether this person, we have one that actually is in center right now, and they were on PD, but they're still very positive about that experience. And then we have a couple home patients. So that was the biggest thing that we used. And that is part of the, the network program. I think the patients actually probably set up as an advocate with the network. So that was one of the biggest differences that we had. The other one is we do have handouts, we do have curriculums, but instead of handing it to the patient, the social worker, the nurse, myself, the charge nurse, and the dietitian, we actually take just one piece of information and set with the patient. So within the first week, we're going over meet your dialysis team, care for the access, whatever access they currently have, and we go over modalities. So those are the three pieces that we're actually going over in the first week of them starting with us.
So, it's interesting. You talk about educating within the first week. And, some of us have worked in the facilities, and then, we always ask, when do you actually educate the patient for the first time? Is it the first day, the first week, the first month? Have you gotten mixed feedback from patients when you've educated them on the first week, or do you feel like they've kind of handled it pretty well?
No, I feel like they've handled it very well. A lot of the new patients coming in are coming out of the hospital and they're afraid. So giving them the information to make informed decisions actually makes it a lot better. So the very first treatment, when they're signing all their consents and stuff, that's when we kind of go over who's in their healthcare team and who they're going to see within the facility. We show them the machine. For Incenter, we show them the Incenter machine, we introduce them to the technicians, and that's just the first day. Then the next time they come in, we start talking about your access, and it's a whole team approach. So even the technicians help to reinforce that education.
Great. Sara, next slide, please. So can you talk a little bit about the ideas that you implemented about the change package? Sara, Eve talked about that earlier. So could you talk a little bit about what you took and implemented from the change package to address your barriers?
Yeah, so the biggest thing is just engaging the staff. I'm very fortunate that we have home therapies right in my facility. It's in the back office. So we do have a home nurse there. She has a great relationship with the staff. So using her to educate the staff on why this is so important, and then just kind of reviewing with the staff that the patients have a better quality of life, they feel better, they look better, and they have more freedom. So we've started, as patients come in, we do assess them as nurses, like, oh, this might be a good home candidate, but we're finding that our technicians jump in this as well. Like, oh, they're only 20 years old. They shouldn't be in here. Like, can we, talk to them about home therapies? Can we give them the packet? So the techs are really getting involved as well. So educating the staff and then engaging them in the education. We also use the care advocates. We have a KCA, which is our kidney care educator. We do track them as well. But, the biggest thing is that we make it a team approach. Everybody is talking to these patients about home therapy. And every once in a while, we'll circle back to our existing patients as well. Like, you're very active. Why are you in center? That's just the biggest thing, is figuring out what the patient's motivation is. Why are you in center? And if they just say, well, this is what I thought I had to do. Well, it's not. And then kind of moving through. But finding what motivates them and moving them forward. We're very fortunate that we have a patient right now that's been with us for 2 years. Kind of mentioned home therapies a few times, but he's going to get his PD catheter next week. So I mean, 2 years we've been working on him, and now he's like, yeah, no, I get it. Let's do it.
Yeah, no, we, as a group, I think we talk about it all the time. How do we motivate patients? What motivates them, and how do we motivate them? And kind of how can we support them, as we listen to them when they start talking about barriers they may have, or maybe myths, or, their idea of what home dialysis is. So we talk about listening, supporting, through the transition. So that's good that you, that it took 2 years. And how is he doing on home? Is he doing well?
He gets his PD catheter next week, so we'll kind of see. He's
Okay.
transitioning in.
Oh yeah. Oh, you'll have to let me know. Yeah, how he's doing after. How long has he been on Incenter?
2 years. Yep.
Oh,
So we
wow.
started on
Okay.
him his very first day.
Mhm. Ah, there you go. Okay. Any questions so far? I don't see any questions.
Donna, I
Okay,
don't see
Sara.
anything. Yeah, I don't see anything
Okay.
in chat, but please, as Sara and Stephanie are presenting, please feel free to drop comments or questions or kudos in the chat for our speakers. Keep this engaging. Ready for
Okay.
yeah.
Next slide. Yes,
Okay.
next slide, please. So this kind of speaks to, I guess, as you work through your PDSA cycle, and you develop your strategies. What elements did you focus on for that sustainment?
Yeah, so the biggest thing is that we do QAI or CQS or whatever you call it in your facility. We do it together. So home therapy is an Incenter because we're both at the same facility. We do ours together. So we do pull the IDT team and the medical director in. We, at the end of the meeting, we talk about what's in the pipeline, like how many HHD patients do we have waiting, PD patients. We start planning ahead. Are we growing too fast? Do we need to get a nurse on staff? And our doctors are extremely supportive of that. The biggest thing is when it doesn't matter what facility, but if we identify an HHD patient, they start cannulating themselves in the facility so that by the time they get to HHD training, they're comfortable with the cannulation and they can actually move on to what matters and what's important, and that's setting up the machine. We also offer just self-care in general. If a patient wants to cannulate themselves, but they're staying in center, we allow them to cannulate themselves. We have a curriculum that if they want to set the machines up, they're allowed to. We don't have any that do that, but we do have a good handful that cannulate with no problem. Our home team is very, very good about being flexible. If they need to train in the evening, we make sure that there's a second person available, because it can be me. I can work in my office, the charge nurse, but we make sure they have somebody in the building with them. But we want to make sure that we can get those patients, trained on their time as well. And then one of the biggest things that we've started just pretty recently, I'd say in the last 10 months to a year, is if a patient can't do HHD or they're on HHD and they're, I hate to use the word failing, but they're unable to do it anymore, we start looking, can we transfer them to PD instead of Incenter, and vice versa, PD to HHD versus them coming Incenter. And we've had success with that as well.
Great, great stuff. Next slide, please, Sara. So I just kind of wanted to show, this is sort of a 10 month period. This Rocky Mountain facility was actually chosen because they hadn't transitioned any patients in the baseline. And in a 9-10 month period, they, according to our data, they have transitioned 7. But I believe you mentioned our last conversation that you've actually trained more than that since
I think
March.
we're at a total of 11 as of today.
Wow, in 10 months. Yeah, that's great. That's great. Great work, I'd say. Anybody have any questions? You know, I find it interesting that you didn't have a home champion, because that's sort of a best practice that we all preach, at least I do, is having that home champion, having that person in center that can really kind of run with it and know a little more, work with the home program and know a little more, have a little more expertise. So when the patient asks a question, they can maybe answer it and then direct them, you know, to the home program and kind of keep that line and that engagement going. So it's so interesting to hear how you decided that wasn't going to work for your team, and you've still succeeded in doing well. So makes me rethink what we've been talking about best practices in our network anyway.
Yeah, no, I mean, we just kind of, you know, my team's very good. I'm very biased, but we found that the home champion didn't work because it was one person doing a lot of the work. And just with a staffing issue, we just didn't have that capacity to release that one person. So we just made it an expectation that it was a team approach. And the biggest thing is we had T-shirts made that said, "Ask me how to rock it at home," and stuff like that. So they would wear their T-shirts, and patients started asking about it. We make sure that we incorporate that kind of education for our existing patients and our monthly patient education. We do it at least quarterly, and we round with the physicians too. So when we get to a patient, we're like, hey, go ahead and talk to them about it, so that we're pulling the doctors in.
Yeah, love that. Yeah, ask me how to rock it at home. That's a great idea too.
We did actually get a couple comments in chat, so we'd like to get those out to everybody. So what is your home dialysis penetration right now?
Sure. So just at the Rocky facility, I do oversee 4, but just at the Rocky facility, which is what this one is, we've had 4 more since January.
Great. And then I think this is a good one. Maybe you can talk about this too. Deborah mentioned, you know, issues with the training distance between the home and the training centers. And I know some areas take kind of the hub and spoke approach, or a centralized training, or satellites. Do you want to talk a little bit about how you move through that training, or how the patients move through that?
Sure. We have quite a few different home therapy offices. So we do place them at the one that's closest to their home. And so we haven't really had that big of an issue. The biggest issue that we've ran into, ours go by provider. So if it's this provider group, they go to this one. If it's this provider group, they go to this one. So that's how we divvy it up. But really the biggest one that we've seen is patients that work, they can't come in and do like that 8 to 1 or 8 to 4. So we've just had to adjust for the evening trains.
Okay, great. And I think, you know, it's a great message too, to hear that, you know, you're working on one patient for 2 years, and, you know, now is the time for him to get that PD catheter. I think, you know, that probably resonates with a lot of folks, having those repeat conversations and finally seeing success there for him.
Yep.
If there are other questions, we can pause here. You can pop them in. If not, Sarah's going to stick around for the next presentation. So if we do have questions for her, we can bring that up. Okay, so I do see here a follow-up comment to that is the issue is 100 miles between patient and nearest training facility. That does sound very specific, and that might be something, Deborah, I'm not sure which network you're in, but that might be something too that you can work on, you know, with your network. Great. We're going to keep it going. I know Stephanie and Sheila are here too, so let's move forward. The next network is Network 14. So Sheila McMaster is going to introduce her speaker. Sheila?
Thanks, Sarah Eve. For Sara, thank you for mentioning the team concept, because we actually started using that last year, asking facilities to approach home from a team perspective, simply because having one champion seemed to maybe be a little too much for the home champion. So thank you for sharing that. Our speaker today from Network 14 is Stephanie Johnson, who is the Senior Director of Operations for East Texas, Northeast Texas, and Southeast Oklahoma for Fresenius. Stephanie's nursing background started in medical surgical care, like a lot of us. Then she turned to dialysis and has worked as a in-center nurse, charge nurse, clinic manager, area manager, director of operations, and now her current position as Senior Director of Operations. Stephanie's been with Fresenius since 2002 and in this current role since 2021. Stephanie spoke with us back in option year 1 because of their really great outcomes and Experience the Difference program. Right now, out of 44 different areas in the U.S., Stephanie's area exceeded their 9-clinic goal of transitioning 59 patients from in-center to home. They actually moved 69 patients and led the Gulf group for 2022. Stephanie, thank you for agreeing to talk with us today. I'm going to turn it over to you and your team.
Thank you for the introduction, Sheila, and for y'all having me today. As Sheila said, I'm going to talk about rolling Experience the Difference and what all we have done in our area. I do have an excellent team, and definitely they are the ones who actually make it happen. And so I want to do a shout out to Cheryl Lundberg, our Director of Operations, and Tiffany Andrews, Area Team Lead for East Texas area. Next slide. So what is Experience the Difference? So to us, we were trying to grow our home program. We needed to transition patients every month out of in-center because, of course, we had lots of new patients coming in, and we needed to free up the in-center staff because we had current staffing shortages. And so one of the things we wanted to do is try to do more hands-on, have the machine there for the patients to see and actually get to feel it and experience the difference. Next slide. So this is a picture of exactly how we set it up in our clinic. So basically, Experience the Difference is where the patient comes in and they'll do dialysis on the Next Stage machine 5 times a week on the Next Stage machine. And of course, it's shorter treatments. And so they can actually see the difference with the machine there, and they can feel how the more frequent dialysis makes them feel. We had lots of patients that on day 2 or 3, they were already coming in telling us, wow, I had no idea it was going to make me feel this good. We could see that, you know, their blood pressure medicines needed to be adjusted. We weren't taking as much fluid off, and they were tolerating their treatments so much better. And we didn't have to worry about blood pressures dropping out like they used to towards the end of treatment. So our patients really got to feel it. And so we did the rolling aspect of it because we had limited staffing. So just like earlier, Sara talked about how they were having staffing shortages. We're all experiencing that. And so it was, how do we utilize what resources we have to kind of shift some of the workload? And we're geographically challenged because we're in a rural setting. And so each of our clinics are pretty much like about an hour away from each other. And so for us to be able to leave the Next Stage machine in one clinic and only do one clinic there were other opportunities for us to move the machine around and possibly encourage other patients to try to experience the difference as well. And of course, to get that equipment around, it was just easier to have a nurse and a tech go together and move it to each clinic and get an expert on the machine comfortable with it, instead of training every single staff member on the Incenter side. And so we also set it up at the very front of our treatment floor. So that way, every time a patient walked by the scale, they would see the machine. And of course, we added some extra decorations to kind of catch their eyes and their attention, just to kind of pop and be like, what's going on over there? What's the big deal? And so that allowed us extra time to talk with the patients about it. Next slide. And so, of course, we had barriers. So, we kept talking to patients and they're like, no, I'm not interested. No, y'all talk to me about that. No, quit talking to me about it. But it seemed like with this, it was a little different because they could see it. And with the float staff that we had, the float staff had that rapport with the patient and was able to build it up, and they trusted that employee. And so they would try it because that float staff would really encourage and be like, yes, you can do this. I know you can. And we actually had some patients that transitioned because they had that extra encouragement. We also had transportation constraints. And of course, like I said, the clinics were at capacity, starting third shifts, and we really didn't have the staff to start third shifts. And so that made it difficult to be able to find a dialysis station for us to actually set aside and designate as a chair for Experience the Difference. The other barrier we faced was that it was a new machine. The team was not comfortable with this new machine, and just trying to get them comfortable, it was going to take some time. And so we had to come up with a plan. So next slide. So our plan was, how are we going to engage our patients? Because we had tried to talk them into trying home therapies because we knew they were a good candidate. They just weren't interested. And so we just had to really dig in to see how we were going to engage our patients, and then training our float PCT and the RN so they could go around clinic to clinic, and also designating that one chair as an Experience the Difference. And so we worked with Next Stage to train and educate our staff. And so if you'll go to the next slide. So here's how we started out. We started out doing education with our patients to kind of prepare them that, look, we have really experienced the difference that is going to come. We're coming, we're going to let you see it. You can feel it, you can experience the difference, and gave them a visualization of what it could look like for them. We had our kidney care advocate come in and do lobby days with the patients. And then we had the Next Stage machine that our Next Stage representative actually came in, and we dedicated a whole day of training with our float PCT, our float RN, so they were comfortable with it and got that hands-on experience off of the treatment floor. And then the next stage, once we went live with the patient, our Next Stage representative was there with us for the whole first week to ensure that the staff was comfortable and competent, got skills check, all of that complete. And so then after that, then the next week, the staff were able to do it independently with this patient. And what we ended up seeing was that we had lots of patients that were interested in doing it after they saw this first patient. And of course, like the day 3, when the patient was really starting to feel a difference and the blood pressures weren't dropping, we had other patients that were like, hey, I want to do it. Can I do it? Put me on a list. When can I start? And so our list grew rapidly. We started out with just one patient and that staff member doing only the one patient on the Next Stage machine. Then as they got more comfortable, we were able to do it to where they could do one in the morning and one in the afternoon and kind of build up, so that way the other patients that were interested could also go ahead and get their turn and try it out. We also took advantage of that time to start working on self-cannulation once the physician approved of it. And so they were able to kind of get a head start on doing some HHD. And then, of course, this was area collaboration because we had multiple clinics that we were trying to rotate through. And so we had to work with our home program managers. We had to work with our technical team. We had to work with our staff on the Incenter. It just took lots of people working together for the pre-work and, of course, during and after. So next slide. So here is an example of one of the clinics. This is our Palestine home clinic. We actually started Experience the Difference May 10th there with our first patient. And this blue line at the bottom, you can actually see how our census went up. So in May of 22, we were at 29. And you can see in January of 22, our census was also at 29. And at the end of November, we crept up all the way to 41. So that's how much our census grew with this initiative in the program. Next slide. This next clinic is Henderson County. And like I said, we kind of rolled it around to different areas. This clinic started in August of 22. And in August, we actually had to get our certification for HHD. So it was our first one. And so it was a little bit of a slower process. But you can see in August of 22, our census was down closer to 14. And as far as April, where we're at 15. So it is helping us grow as home programs, and it's also helping our patients being more encouraged to try a new modality. Next slide. So Next Stage actually recognized our clinics because of all the growth we had, and we were given the Rising Star Award and the Pioneer Award for all of their efforts that they did. So with Palestine, like I said, our census, we were packed. It was at 94. We had 3 patients that completed Experience the Difference and chose HHD. We had 2 patients that were encouraged just by the increased awareness, and they chose HHD without even going through the Experience the Difference. And then we had 6 additional patients that were admitted with PDCAS. And of course, our ETD program is still rolling, and we just rotate through all the clinics in our area and continue to offer it to our patients as they come in. Next slide. So the biggest thing is to discover the patient's why. We've got to make that commitment to our patients so they can feel the difference, because if we don't allow them to feel the difference, they're not going to be able to make that commitment to do it. And so it starts with an empowering the patients and letting them know that, yes, I believe you can do this. I know you can do it. And just giving them that extra encouragement. And then, of course, working with, okay, what is your schedule? how can we help you with this? And then, of course, empowering your team. We really, I think the key is to find the right person for it, because if you don't have a staff member who is engaged and really excited about it, it's not going to work. So it's a really big key to make sure that the person you have assigned to help with this, that they're on board and they have that rapport with the patients, because they trust them, and if they believe in them, then of course that'll lead to success later. Next slide. So some of the opportunities we identified had to do with selection of the clinic. So what we realized was that first off, we didn't expect for it to take off as much as it did. And once it did take off, we had the same home program staff, even though they were in different clinics. Sometimes they shared staff. And so we kind of overwhelmed those clinics. And so if you try to do this, definitely think through that better than I did, because we overwhelmed them. And so we kind of had to back off a little bit to allow them time to breathe, especially since the HHD training takes longer than the PD does. Blocking off chairs, just knowing that it's coming. And when you do have an open chair, instead of putting a new patient in there, go ahead and set that chair and kind of hold it, so that way you do have an available chair to be able to run Experience the Difference. And then be ready to review all your patients on the pipeline program, because you've got to plan it and see, okay, when do I need to order my equipment? When do I need to set up my account? Those different things. Excuse me. And then we had home therapy champions. So we had an annual training that we did in 22. We have not done that in 23. We're working more towards having someone in the clinic to actually be an Experience the Difference champion. And so instead of having a float person, we'd like to have a dedicated person in each clinic, because there's been lots of interest and lots of staff asking, can I learn how to do that? I really want to do the Next Stage machine. So we're working on that this year. Next Stage accounts, we found out real quick for Incenter clinics that did not have a home therapy account tied to it, or a home therapy program tied to it, that we did not have accounts set up. And so we had to get those worked going. And then the iPads, they were useful for the Incenter staff and the patients to actually be able to see the different alarms that look similar to what they see on the T machines. And then also having a spot to actually set the Next Stage machine on. We tried to use different equipment, and anyhow, the chassis in the garage was the best thing. And then technical, like I said, we had lots of patients moving, and so we kept our technical team running. And so just trying to coordinate all that and remember how much technical does on the prep work for our home patients, and trying to assist with moving the equipment and the supplies around once we got ready to roll it to a different clinic. Next slide. And so that is all that I have in my presentation, but anyhow, if you have any questions, definitely let us know.
Great, thank you, Stephanie. We do have a couple of questions that came through chat. Love the learning too about overwhelming perhaps the training nurses, down the line and planning all that out. So thanks for, being vulnerable and sharing kind of lessons learned. We had questions here about the billing. So is that something that you could talk to about how to bill for the 5 days a week dialysis, when we know that you can only do dialysis 3 times unless it's UF or something? So how did you guys work around that?
So we actually had a special order from the physician that was multi-frequent dialysis. form. And so that had to be filled out ahead of time from the physician, outlined with the ICD-10 for the reason for the increased dialysis frequency.
Okay, good. Thanks for that. And then you talked about, the teaching the new staff. So any other reactions there? It seems like the staff were interested. You want to speak a little bit more about kind of what their experience was?
Sure.
And then I have more questions, so don't go anywhere.
Okay. So they were really excited just because it was something new, and definitely I think exposing them to that, we talk about it all the time. We got to move patients to home. We've got to get them to home. And so for them to actually have a chance to see it, touch it, feel it, they're like really engaged. And of course, when we were rolling it out, we had one-on-one time to be able to learn the machine, but not everybody had the full training on the machine. And so those that didn't get the full training, they wanted that. And so that's what we're working towards being able to do for this year.
Great. And so the follow-up there is, just to clarify, you had one next stage machine that you used for multiple patients?
Correct.
Were there any P&Ps that had to be updated or anything different?
So we did have policies and procedures that we had to approve. We had a checklist of basically implementing Experience the Difference, and it had the policies governing body approvals, next stage policies, all those items that were in it. So it takes a good 4 to 6 weeks prep work before you can even pull the trigger and start running your first patient.
Good, that lead time is helpful there too. And so just another question or comment here was, how did you, it sounds like you have a great relationship with your next stage rep. For those folks who maybe haven't been able to get a hold of theirs or don't have that relationship, do you have tips for other FAs or folks in operations on how to work on that relationship with next stage?
So my contact person is Nicole Ludnicki, and she is amazing. And we actually are starting a HHD program here in Mount Pleasant, and I talked to her this morning. So she's amazing. I'm sure she would be happy to give me contacts for anyone who is needing assistance in connecting with their local person.
Okay, great. And that's something perhaps that the NCC can pop in the email summary of this call. And then just another follow-up there, we talked to Sara about her training. Do you want to talk a little more about the training, if these were, satellite, if they were the home programs within Incenter, and, just a little bit there again about that training flow?
So as far as ours, it varied. We had one clinic that went to a home program. So for Palestine, that was a home standalone clinic. And so we did the training at the home clinic just because there was more room. The equipment was already there, and it was just easier to train the staff there. Now we have done it to where we've done it in the clinic if they have a joint program. We've done some of that combined. So it just kind of depends on the scenario, what your clinic's like, and what works best. There was some prep work involved ahead of time. We had some LMS training that the staff had to do ahead of time, and that's just our computerized learning modules. So they did that prep work, I would say probably 2 weeks before the next stage rep came and did hands-on training with the staff.
Great. And one follow-up question about those policies and procedures. Were those things that are, FMC proprietary, or how did you go about kind of writing those or approaching those P&Ps for this?
So those are through Fresenius, and so those were the policies that we did adopt. Okay.
Well, I'm going to pause here. We'll give everybody a chance. Lots of good comments and questions. If you do have those, please make sure that, you can put them for everybody so we can all see your comments and questions. Gonna pause here. Let's take a break here while you think about some of this, and we'll get back to the polling questions. So in chat, now that you've heard these presentations, does this help kind of sell you on using the ESRD NCC home dialysis change package? Kind of, what's your temperature there on, using these change packages and maybe adopting something from the presentation today? And then we still have both our network representatives and our facility, representatives Stephanie and Sara on the line. So if you do have more comments and questions, we can hang out for another minute and see. If not, then we'll roll forward and close up the, okay, so they have been using ideas. Great presentations. Again, lots of kudos to the team, in the comments. So Stephanie, Sara, please take all the accolades you're getting. This is great stuff. And I think it's really encouraging, right? Especially for, folks at the facility or operational level to know that we're all in this together and, being persistent with these things. Great. Some great ideas. People are going to bring this back. It seems like lots of people being sold on this experience and difference idea, great ideas. Again, really creative approaches, some tried and true methods and some creative ones. We're going to go forward. If you do have additional comments or questions, you can pop them in chat. So this is moving, right? We're trying to take from the learning that we all just experienced to action. That's the LAN. And so, share these practices with your colleagues, take other things from the change packages, even just the energy and enthusiasm we get when we're all together talking about these things, let that, take that back to your home clinics, to your teams. I do have a QR code and the address for the NCC home dialysis change package. If you haven't checked that out yet, just put your smartphone on the camera feature and that little QR code will take you right to the home dialysis change package. You can email it to yourself and be done and have it in your pocket for, for later today or tomorrow morning or whenever you're ready to tackle that. Great. Well, again, we just like to thank our presenters today, Sheila, Stephanie, Sara, Donna. Thank you so much. Thank you for everybody and your time and attention today. The NCC, please check us out. We're on social media. You can see there and lots of other great resources just at our regular website there, esrdncc.org. After you close your browser, you will be redirected to a survey. We would really love it if you would just take that 1-minute survey. Let us know how we're doing so we can adapt and change these and make sure that they're applicable to you. Thank you so much to everybody today. Have a great day and take care.